Welcome to our deep dive into autoimmune pancreatitis, or AIP. This fascinating yet challenging condition affects the pancreas, an organ vital for digestion and blood sugar regulation. In this video, we'll explore what AIP is, its causes, how it impacts the body, and what can be done to manage it. The exact cause of autoimmune pancreatitis remains somewhat of a medical mystery, but as the name suggests, it's believed to be an autoimmune disorder. This means the body's immune system, which normally defends against invaders like bacteria and viruses, mistakenly attacks healthy cells in the pancreas. Researchers suspect that genetics and environmental factors likely play a role in triggering this autoimmune response. There isn't one single identified trigger, but some theories involve molecular mimicry where a foreign substance resembles pancreatic cells, causing the immune system to attack both. When the immune system attacks the pancreas, it triggers inflammation. This inflammation leads to swelling and damage within the pancreatic tissue. Over time, this can result in fibrosis, or scarring, which impairs the pancreas's ability to produce digestive enzymes and hormones like insulin. The inflammation can also affect the bile duct, causing narrowing or strictures, which can lead to jaundice. In essence, AIP disrupts the pancreas's critical functions, leading to digestive issues and potential metabolic complications. Autoimmune pancreatitis is relatively rare, though its prevalence may be underestimated due to diagnostic challenges. It's more commonly diagnosed in middle-aged to older adults, typically between the ages of 50 and 70. Men are also more frequently affected than women. While it can occur in individuals of any ethnicity, certain populations may have a slightly higher risk, although more research is needed to confirm these trends. The signs and symptoms of AIP can vary, but some common presentations include abdominal pain, often described as mild to moderate and located in the upper abdomen. Jaundice, a yellowing of the skin and eyes, is also a frequent symptom due to bile duct obstruction. Many individuals also experience weight loss, fatigue, and signs of diabetes, such as increased thirst and frequent urination, as the pancreas's ability to produce insulin is compromised. Some people may have no symptoms at all, and the condition is discovered incidentally during imaging tests performed for other reasons. Diagnosing autoimmune pancreatitis can be challenging as its symptoms can mimic other pancreatic conditions, such as pancreatic cancer. The diagnostic process typically involves a combination of imaging studies like CT scans or MRI, which can reveal pancreatic enlargement or changes in the pancreatic duct. Blood tests are crucial to measure levels of I4, a type of antibody often elevated in AIP. A pancreatic biopsy may also be necessary to examine pancreatic tissue under a microscope and confirm the presence of characteristic inflammatory cells. A key component of diagnosis is often the response to steroid treatment, which typically leads to significant improvement in symptoms and imaging findings. Autoimmune pancreatitis is broadly classified into two main types, type 1 and type 2. Type 1 AIP, also known as lymphoplasmacytic sclerosing pancreatitis or LPSP, is characterized by the presence of IgG4 positive plasma cells in the pancreatic tissue and is often associated with other autoimmune conditions like inflammatory bowel disease or sclerosing cholangitis. Type 2 AIP, also known as idiopathic duct-centric pancreatitis or IDCP, is less common and doesn't typically involve elevated IgG4 levels or other systemic autoimmune manifestations. It is often associated with inflammatory bowel disease IBD, particularly ulcerative colitis. Distinguishing between these types is important as it can influence treatment strategies and long-term management. The cornerstone of treatment for autoimmune pancreatitis is corticosteroids, such as prednisone. These medications work to suppress the immune system and reduce inflammation in the pancreas. Typically, patients experience a rapid improvement in symptoms and imaging findings with steroid therapy. After the initial course of steroids, a maintenance therapy, often using lower doses of steroids or other immunosuppressant medications like azathioprine or 6-mercaptopurine, may be necessary to prevent relapse. In some cases, if there's a significant narrowing of the bile duct, endoscopic procedures like stent placement may be required to relieve the obstruction. For patients who don't respond to steroids or experience frequent relapses, other immunosuppressive agents such as rituximab may be considered. Currently, there are no definitive ways to prevent autoimmune pancreatitis, primarily because the exact cause remains unknown. However, maintaining a healthy lifestyle, managing other autoimmune conditions if present, and promptly seeking medical attention for any persistent abdominal symptoms may be beneficial. Avoiding potential environmental triggers, if identified in future research, could also play a role in prevention, but more studies are needed in this area. The prognosis for autoimmune pancreatitis is generally good, especially when diagnosed early and treated appropriately. Most patients experience significant improvement with steroid therapy and can lead relatively normal lives with ongoing management. However, relapses can occur, requiring further treatment. Long-term complications, such as pancreatic insufficiency leading to digestive problems or diabetes, may develop in some individuals, necessitating enzyme replacement therapy or insulin management. Recent research focuses on identifying biomarkers for early diagnosis, understanding the underlying immune mechanisms, and developing more targeted therapies with fewer side effects. Studies are also exploring the role of genetics and environmental factors in AIP development to potentially identify individuals at higher risk and develop preventive strategies.